go over today more of like what makes things different in pediatrics. There are certain seizures that you're going to see in kids that don't happen in adults, but can progress to adulthood. So I do, in the first few slides, I have some goals of today's lecture, and I also, those are the presentation. We're going to go over many different types of seizures. We're going to go over how to deal with pediatric status epilepticus. We're also going to talk about febrile seizures, neonatal seizures, epileptic spasms, so many different types of seizures that you may not have covered already that are unique to kids. The other thing is that the next two slides are just the objectives of today's presentation. And we're going to go over some cases throughout the presentation as well. So you'll learn like how to manage certain situations or what type of agents to use. So let's talk about the overview within some introduction. So seizures in general are a common neurological disorder in pediatrics. It's probably one of the most common neurologic disorders that we see in kids. And some of the times it's just acute and it resolves and it goes away. They just have one single episode and it doesn't come back. But then other times that single episode can lead to multiple episodes. And unfortunately, the multiple episodes we tend to have to treat. Unlike adults sometimes, in pediatrics, we think the seizures could be controlled, and if they're controlled for a period of time, and you slowly wean them off of medications, they may never come back again. But at times, it may be something chronic, and it could lead to multiple seizures on top of that. So new diagnosis of seizures on top of the ones that they already have. So it really depends on what type of path it's going to. There are seizures within the first year have an increased risk of cognitive delay, meaning that if I have a child who develops a seizure, let's say at 9 months of age, more than likely, depending on the severity of that seizure activity, the child is more likely to have some type of learning disability or some type of cognitive delay in the future compared to somebody who's never had a seizure before 1 year of age. And lastly, there are some special considerations we have to think about. For those of you that work in the pharmacy, whether it be a hospital setting or even in a community setting, not all these drugs are pediatric friendly, meaning that they're not always available in a liquid formulation. They're not always available in a sprinkle formulation. The other thing we have to think about is that, with the milligram per kg dosing, pediatric drug dosing with the special considerations are usually weight-based dose. So when we weight-based dose, we have to make sure that we have to worry about when they have accelerated growth. If I have a kid who's 5 kilograms, let's say this year, and then next year they're like 8 kilograms, that's almost going to be like a 10-pound difference. So I have to make sure I weight adjust those medications so that they're still within therapeutic range. So kids have growth. They're not going to be on the same dose like adults do for their chronic time. They're going to need to be weight adjusted and increase their dose. The other special consideration is that we know these drugs, these anti-epileptic drugs, have adverse effects, right? A 3-year-old may not be able to comprehend what those adverse effects are, and they may not be able to tell you, oh, I'm feeling a little bit of a headache, or, my stomach feels funny because I think something is, I think it was the medication. A 3-year-old versus a 5-year-old versus a 10-year-old is not going to be able to verbalize all that information to you. So keep that in mind that sometimes when we look at side effects that occur in these kids, we have to be careful to make sure that they can comprehend and look for other signs that may tell us that they're actually experiencing a side effect. So we may do some laboratory tests, bring them to more frequent visits to their neurologist. So the goals of therapy in seizure management is really no different than what we have the goals of therapy in adults, how we manage seizures. One of the things we want to do is, of course, to maintain optimal seizure control without using as many drugs as we want. So ideally, we just want to use one drug to control their seizures. And if that one drug does not work, we want to make sure we optimize that one drug with their dose before we tell them that they're in failure. And then we add on adjunctive drugs if that's not good enough. We also want to prevent any type of behavioral aberrations. There are some medications we're going to go over later that have adverse effects, particularly in pediatrics, where they have behavioral adverse effects, such as aggression, or maybe even suicidal ideation. So we want to prevent that from happening. And then the principles is really to establish the diagnosis and exclude any other thing that we can think about. So we want to make sure it's just a seizure neurological problem as opposed to something else that's causing it. The other thing that we want to do is make sure that we get a good history too. Get a good medication history of what agents have they tried on in the past. Because there could be some drug therapies that they may have used, and if we restart it, we know they already failed it. Why would we want to use it again? The other thing is that we have to identify the seizure type. Not every seizure is treated with the same medication. Some anti-epileptic drugs will have detrimental adverse effects if we use the wrong medication. So not one size fits all is really the key thing. So whatever seizure is being diagnosed, you need to make sure that which one is the first line of therapy, because these other agents may exacerbate that seizure activity. And of course, the other choosing an anti-epileptic drugs, those are other considerations we're going to think about. So titrate dose to achieve desired serum concentration. Now, many of these medications, and I'm sure you learned in Dr. Wagner's lecture, the older generation agents do require drug levels. The newer generation agents don't really require as much drug levels. They're more at a long-term steady state. We know that we don't really usually have to monitor levels. But if you see a child coming back with more frequent seizure activity, you kind of want to check a level to make sure they're within the therapeutic range. So that's one of the things we want to do, as well as look at their clinical signs and symptoms to see how many seizures have they had. And then consider any free anti-epileptic drug levels. Can anybody name a free anti-epileptic drug level that we may want that's used to treat seizures? A free level? Phenytoin. Phenytoin is the classic one. And phenytoin we do still use, especially in acute seizure activity. Now, it is dependent on certain factors, so sometimes you need to check the albumin level because protein binding with some of these agents can be affected. So if I have a baby who has low amounts of protein, you're going to assume that majority of their levels are going to be free levels. So they may have a higher risk of toxicity. So you want to check those as well. And any malnutrition, age is the neonates. The neonates is where we're most concerned with, and the neonates is where we more commonly sometimes may need to use phenytoin. So being sure that the drug dose is appropriate. That's one of the key things. I just told you, kids grow. Adults, we start on the anti-epileptic drug, standard adult dose, and we can titrate, to effect. But in kids, if they've been diagnosed with seizures at 3 years of age, and if they're on the same medication, they're probably going to need a dose change in the next 3 to 6 months, depending on how much weight they gain. And if you do not, so what happens? Like if you don't weight adjust their dose as they're growing and aging, what's going to happen to their therapeutic levels? They're going to go down. And you don't want that to happen because they may have a seizure activity just because we did not weight adjust them to the right dose because they gain weight. And that's probably one of the common things we see is that this kid, gained like 10 pounds over the past 3 to 6 months. But that could be normal for them to gain that much weight. And you have to consider weight adjustment because if not, over time, their doses are going to be below the recommended doses and their levels are going to drop and they have a potential risk of getting a seizure activity. And the key thing is to make sure they're compliant. Many of these medications require the administration from an adult or whoever is their caregiver to give it to the child. So you want to make sure that they're compliant. So we want to rule out to make, and if they're non-compliant, educate, find out why they're non-compliant or non-adherent, give them some tips, and then, but don't, make any decisions that, oh, this drug is, they failed this drug because it didn't work, when they actually were non-compliant with the medications. We don't want to label them as failure if there's something else that's going on. And patient education is really the key thing. There are certain side effects that we know we can expect and see as we work with our children. So what we can do is kind of lay out what those adverse effects is, what parents or legal guardians can look out for before starting those drugs. So this is just a list, and it's not even a conclusive list of the common AEDs that we use in pediatrics. These are the first generation. So first generations are generally our older agents, and I'm going to talk about the difference between the efficacy among the two of them in a little bit. And then these are our second generations. So second generations meaning the newer anti-epileptic drugs that doesn't require some of the things that we do with the first generation. So what's the difference between the two of them? So the comparison. So although we know the first generations are older, okay, so although we know they're older, what does that tell you sometimes? What do you think? What do you think about the side effects? We'll start with the easier one. More side effects, very good. So there's probably going to be more side effects. How about drug interactions? More, probably more drug interactions. Do you think this first generations, the older ones, require more therapeutic drug monitoring? Yes. Okay. So everything we just said with that is the opposite between the safety of the newer generations. So the newer generation agents, we don't usually need to draw levels. There's not as much drug interactions as opposed to the older ones. And there are still side effects, but they may be different side effects. The newer generations produce basically newer adverse effects that we may not see with the older ones. As far as efficacy, they're equally efficacious. Other than the safety differences among the two groups, they're really efficacious. So but we're transitioning more of the newer generations because we do find that they're less cumbersome and they tend to be more safer. So you'll see some of the differences between that. And the other thing to keep in mind is, other than what we just talked about here, actually this is the summary of everything we just said. So initiating of AEDs, ideally one drug. We're not going to start on 2 medications. We're going to start on 1 drug. Okay? 1 drug, monotherapy, is the best thing to do to initiate anti-epileptic drugs. And the recurrence of absence, myoclonic, and infantile spasms is also known as epileptic spasms, which we'll talk about, is certain. So there are certain seizures we know, if they're diagnosed with any of those, absence, myoclonic, or infantile spasms, we know that if we don't treat them, they're probably going to have neurological damage due to subsequent seizure activity. So those are the type of seizures you must immediately initiate anticonvulsants. So that we know for sure. A single episode of afebrile tonic-clonic seizure, so a one-time episode where their EEGs are normal, we don't usually start drug therapy. And the reason for that is because these drug therapies usually have a lot more side effects than the risk versus benefit. So a one-time convulsive, but their EEG is absolutely normal, there's no need to start drug therapy. And then the other thing to keep in mind is that more than 2 afebrile seizures within 6 to 12 months, so in other words, if they've had multiple seizures during that time, then we may initiate therapy. So even though people have reported a single seizure episode, they're not considered having epilepsy. Epilepsy, remember, is multiple subsequent episodes. A seizure may be just one single episode. It doesn't always require a treatment if they're not going to have subsequent episodes. So we try to do it very liberally. We don't give everybody drug therapy because we know there's just much more adverse effects as opposed to that. So this I have here, with the next 2 slides, you're going to notice that it's a summary of all the indications of the most appropriate agents to use for neonates and pediatrics for the seizures. We're going to go through each one. As part of the exam, all I need you to really know is only the first-line therapies. So with this slide, you'll notice that we're going to talk about all these different agents as well, and also these seizure activity, but I just want you to know the first-line therapy when given the patient case for this slide and the next slide. And we'll refer back to these slides as we go over each individual seizure activity. Now, therapeutic drug monitoring, I'm not going to go over what Dr. Wagner already went over with therapeutic drug monitoring. What I do want to go over is really for some of them, we have to check levels with accelerated growth, because we know that sometimes with the dosing changes and everything, we may need to go up higher or weight adjust their doses. The last thing we wanted to also go over is valproic acid. Now, valproic acid, if you look up the therapeutic range, is usually 50 to 100. So if I have a child who's on valproic acid and their level is 75, that's good. But if I have a child who's uncontrolled and their level is 75, in pediatrics, we can push up the valproic acid level from 100 to 150. So any reference range you'll look at, it'll say that it's 50 to 100, but in kids, we can go up to 150 with valproic acid if we need to. And that's important to know. One thing is that valproic acid, if I told you that the reference range is 50 to 100, what does that tell you about the drug already? Is it wide therapeutic window? Yes. So I have a lot of wiggle room to work with that with valproic acid. Certain kids are not controlled up to 100, and we found that it was safe to push them up to 150. So for some reason, between that 100 to 150 mark, they actually did better with that. So that's another difference and unique thing that we find in kids. Now, my lecture is going to be a team talk lecture. I have two residents who's doing a teaching rotation with me. So I'm going to have Iris introduce herself. Iris Chen here. She's one of my PGY1 residents, and she's going to go over the next part of the lecture.
Resident at Jersey Shore University Medical Center. So today I'll be going over a section about status epilepticus. Now I know you guys already had a lecture on that for the adult population, and in that sense it's kind of going to be a bit of a review. What I'll mainly be going over then is the difference between adult and pediatric status epilepticus treatment. So let's see. As a basic definition, you guys already know that status epilepticus is 5 minutes or more of continuous clinical and or electrographic seizure activity, or it could be a scenario in which there's recurrent seizure activity without recovery, so the child isn't returning to their baseline status between the seizures. And these are classified in several ways. The first would be generalized convulsive SE or GCSE, non-convulsive SE, and then refractory SE. So for GCSE, this is the type of status epilepticus that is very classic. It's with the convulsions associated with the rhythmic jerking of the extremities. Pediatric mortality for generalized SE is 3 to 11%, so it's fairly high. Now moving on to non-convulsive SE, this is essentially the electric abnormalities are happening, so there's a seizure going on the EEG, but you don't see those classic jerking movements. And the general population, 30-day mortality is 65%, so that's adults and pediatrics. It's not a pediatric-specific number. Finally, we have refractory SE, and this is essentially either types of the first types of status epilepticus, but it's non-responsive to standard treatment regimens. And for pediatric mortality, symptomatic mortality is 20% in that case, and for idiopathic RSE, the pediatric mortality is 4%. So as you can see from these numbers, it's really important that the clinical team, the medical professionals, can both recognize and know how to treat these different types of SE. So in your adult SE lecture, you went over the reasons that adults might go into status epilepticus. For the pediatric population, though, the most common reason is really prolonged febrile seizures, which my co-resident Giselle will be going over. But other very frequent reasons for going into SE include CNS infections, especially bacterial meningitis, inborn errors of metabolism, which are these rare genetic disorders. So basically you can't produce and utilize your energy correctly. Certain disorders include galactosemia, in which case the body can't utilize galactose well, and phenylketonuria, in which case your body can't use phenylalanine correctly. So these will also build up in the body and cause problems. The final very frequent reason for SE is also ingestion in the pediatric population. So how do we treat SE? It's very it's very regimented in the sense of timeline. So at 0 to 5 minutes, when the EMS gets onto the scene after they hear that the child has gone to status epilepticus, they'll basically want to make sure to stabilize the patient first, so airway, breathing, circulation, the basic needs for the child. Then you want to be able to time the seizure from its onset and monitor vital signs, further assess and address oxygenation if that's a problem, initiate ECG monitoring, and collect finger stick glucose and adjust that as needed. So in a case where the child is hypoglycemic, they will give dextrose and water. The percentage will differ based on the child's age. And finally, they want to attempt IV access for 2 reasons. You want to be able to collect the applicable labs, so CMP, electrolytes, also any drug levels. Perhaps this child already has a history of epilepsy and they're on an anti-epileptic, in which case you would want to see what their levels are at that point. Or maybe there might be a suspected ingestion as well, and that might be a reason to get it. The other reason, though, is you want to make sure you can try and initiate drug therapy, and IV access would be the best way to get a medication into the patient quickly. Then moving down the timeline to 5 to 20 minutes, you start initial therapy phase, and benzodiazepines here are really the initial choice of therapy. So these 3 options up on the screen in the top section are equivalent first-line options. Because you guys don't need to know the dosing or the frequency, I haven't put it there, but just know that those first 3 options, they're equivalent. So you could use intramuscular midazolam, IV lorazepam, or IV diazepam. So it's only one of the 3. You don't use all 3 at the same time. However, if none of the options above are available, you can choose one of the further 3 options at the bottom. You have the options of IV phenobarbital, rectal diazepam, or midazolam again, but the intranasal or buccal formulations. So as you notice, a number of these options are not through IV access, so that's important to remember, just in case for some reason or another you don't have that IV access, that you know what other types of routes you can use to help the patient. Moving on to the next stage for second therapy, the timeline is now at 20 to 40 minutes. At this point, there's no evidence base for first second therapy of choice, so you would choose one of the following second line options and give it as a single dose. So you have the options of IV phosphorytoin, IV valproic acid, and IV levetiracetam. Because these are second line options for this, for treating SE essentially, though you do have to remember there are certain issues with these drugs potentially. Specifically for IV phosphorytoin, you really want to avoid using this in patients with a history of primary generalized epilepsy. And then for IV valproic acid, does anyone remember what a big toxicity for valproic acid is? So for children that are less than 2, you're really worried about hepatotoxicity, and then also potentially hematologic issues, including thrombocytopenia. So even though these are options, you do still have to consider the patient as a whole. You're not just treating their SE, you're treating an entire patient. If none of the options above are available, though, IV phenobarbital is another alternative. So finally, we have third therapy phase at 40 to 60 minutes. Again, there's no clear evidence to guide therapy in this phase, so choices are going to be one of 2 options. You're either going to repeat the second line therapy, the one in the last slide that I just went over, or you could actually move on to anesthetic doses of either midazolam, pentobarbital, or propofol. But with anesthetic doses of medications, what do you guys think is the big issue there? Can the patient just receive this like any other drug, or do you have to prep them in some way to make sure that they're still stable after you give it to them? Yeah, you have to prep them. How do you, when someone's, yeah, you have to intubate them and to make sure that they're still getting oxygenated. So again, it's an option, but as you move further and further down the line, you have to take more and more considerations, and you have to keep these considerations in mind. So I know I just went over a lot, but we're just going to go over one review question. So which of the following medications can be used as first-line therapy for a 15-month-old child with a history of primary generalized epilepsy presenting with GCSE? Is it A, IV phosphorytoin, B, oral levetiracetam, C, rectal diazepam, or D, continuous infusion midazolam. So I'll give you guys a second, and then we can go over the answers. So I'm hearing a lot of C's already, so that is the correct answer. And I'll just go over why the other answers are incorrect though. So for IV phosphatidylin, A, it's not a first-line therapy, but B, I also mentioned that you also don't want to use this in patients that you know have a history of generalized epilepsy, so that's why A is incorrect. For B, oral levetiracetam, mainly it's that oral route that's incorrect in this case, because when a child is actively seizing, oral route is not going to be where you can get the drug into the patient. C, you have rectal diazepam, and just a quick kind of fun fact question, does anyone know what the outpatient rectal diazepam is, the brand name that we sometimes dispense?
How's it going?
So there's a brand rectal diazepam called Diastat that can be dispensed outpatient, and basically the parents have to be instructed on how to apply it rectally, but the pharmacist should be drawing up the correct dose so that should the patient need it, the parent can just administer it. And then finally D, we have continuous infusion midazolam, which you know isn't a first-line agent because of its need for intubation.
And just for everybody's knowledge, like the Diastat, the rectal diazepam, why do you think when a patient is diagnosed with seizures, you might want to send them home on rectal formulation? Yes. Just in case they have a seizure at home, exactly. So a family member is not going to have like intravenous benzodiazepine readily available at home, nor are they going to even know how to give an intramuscular injection or give an IV injection of it. So if they live in, let's say they live in the boonies and it's 50 minutes away to the closest hospital and it takes EMS like 20 minutes to get there, you don't want that child to be at home seizing for 20 minutes for EMS to get there. That's not going to ideally happen. So you want to give them some type of home right. Now, rectal diastat, we've had lots of families complain, why don't they make a better one? Why do I have to pull down my child's pants to give them, their rectal diastat, maybe in public? Like these are things we didn't know about. So there's actually now an that's still being investigated. There's the intranasal midazolam, which is that's going to be available. So that's going to make families' lives so much better with their quality of life. So instead of giving them rectal diastat, we may in the future, hopefully it'll get approved soon, we may be able to give them a commercially available intranasal midazolam instead.
So hi everyone, my name is Giselle. I think some of you might remember me from Hair, Skin, and Nails, those who went. Don't think I forgot. But today I'm going to be going over pediatric febrile seizures. So just some epidemiology. So febrile seizures are the most common neurologic disorders in children, and it's very age dependent. So it's most common between the ages of 14 to 18 months, but it can also appear at 6 months to anywhere less than 5 years of age. And it affects roughly 2 to 4% of children less than 5. And up to 5% of those children will actually have a febrile seizure in their life. And then 1 of 3 of those kids will actually experience another one in their childhood. So as you can see, it's pretty common. So what is febrile seizure criteria? So 1, febrile, what does that mean? Have a fever. So a child's gonna have a temperature of 104 Fahrenheit or 38 degrees Celsius, but they'll also be seizing at the same time. The child should also be greater than 6 months of age or less than 5 years. They will also have any absence of central nervous system infections or any type of inflammation. They will also not have any type of acute systemic disorders, and they won't have a history of seizures as well. So what are some clinical features that you'll see in these types of children? So we'll see, the child will be sick for usually that first day, and they'll have a fever, and then they'll present with a seizure. That's most common what happens. You'll also see the tightening and contracting of their muscles. It can either be on both sides of their body or on one side of the body. And this is what you would typically think of what a seizure is, whether it's tonic-clonic, if it's focal, but I'm pretty sure you guys have reviewed in your adult seizures. And it can also be rhythmic jerking. The child will also have loss of control of their bodily functions, so they will urinate, possibly defecate.
They may vomit, and what's also pretty common is they'll bite their tongue. And they'll also appear cyanotic. So when a person a lot of time is seizing, they may stop breathing. So when you stop breathing, they may become a bluish color. So children often present that way. So what are some risk factors of febrile seizures? So one, automatically, is having that high temperature. Two, they may have a viral infection. They may also have a family history of seizures. And then there's two categories of febrile seizure. So our first category is simple febrile seizure, and that's the most common. So here, these are the general tonic-clonic type of seizures, and they'll usually last less than 15 minutes, and they will not reoccur again within 24 hours. Our complex febrile seizures, on the other hand, are less common, but they are focal seizures, so they're usually presenting on one side of the brain, and it's usually one-sided rhythmic jerking. And that duration is greater than 15 minutes, and it will reoccur in 24 hours. So here, I love pictures. If you guys remember, I probably grossed you out with some of my pictures before, but this one's nice. So this is kind of showing you the different factors that will ultimately affect a baby. So if we look at environmental factors here, environmental triggers, so those are your viral infections. So measles, mumps, rubella can do this. And it can also be with or without temperature, but usually when a child is sick, they'll develop that temperature. So that's how we know as physicians there's something going on, because they present with a temperature. We also have neurodevelopmental vulnerabilities. So if the child has some type of issues with their sodium channels, or if they have altered mental or altered blood-brain barrier, this can also cause the seizure. And then ultimately, there are genetic susceptibilities. We're not really going to go into that today, but just know that children who have this genetic issue can develop febrile seizures. So assessment and diagnosis. So what is really our first thing that we want to do when a child presents to us? We want to take a really great history and physical examination. With this information, we can find out a lot of things about the child and hopefully make a diagnosis. We also want to determine the source. So why is this child developing this fever? What is causing him to have this temperature and then ultimately developing the seizure? So we want to distinguish it from other infections. So is it a respiratory infection? Is it some type of viral infection? Could it be common acute otitis media, which children often present with? And then we want to look at our laboratory values. So one of the great laboratory values that we can take is a lumbar puncture. And that's really just to rule out central nervous system infections, such as bacterial meningitis. So in children with bacterial meningitis, they, like Dr. Sue mentioned, they can't express to you what they're feeling. They can't say, my back hurts, I can't move my neck. They won't be able to do that. So a fever is actually our first clue that something may be going on. And then we have our CT and MRIs. But really, a CT and MRI should only be taken if the seizure is prolonged and at least is some type of deficit. And it could also be with complex seizures as well. So one of the great things as us as pharmacists, that we can provide a lot of education to parents. So if a parent sees their child seizing, it's a horrifying thing to see. So what we could really do is just provide them with education. So you want to tell them, if your child is to start seizing, placing the child on the side, making sure nothing is in their mouth, and also not to try to stop the jerking movements, let them pass. You also want to let them know that if the temperature is less than 102 degrees Fahrenheit, and the child is otherwise healthy and normal and isn't presenting with any type of issues like looking like he's going to become really sick, we really don't need to treat, and the child is less likely to develop another seizure. And treatment's only recommended if the child is experiencing symptoms of the fever. So if they're fussy, if they're crying, if they're uncomfortable, then we can actually treat the patient. And then unnecessary treatment is actually causes negative long-term effects, so it's another thing that we should really explain to our parents. So what are our risk factors for a reoccurrent seizure? So this is something that parents will probably be the most concerned with. My child's already had this febrile seizure. Is it going to happen again? Can I prevent it? What can I do? So the best thing is to really determine their risk factor. So if the child is less than 18 months of age, that's a risk factor. If they've had seizures before, or they have a first family relative that has a seizure, that also puts them at risk. If they've had a relatively low-grade fever that's associated with the seizure, that can also do that. And also, if the duration of the fever was less than an hour before the seizure onset, studies have shown that actually can be a risk factor, along with multiple seizures in their past and any type of nursery or child's care. So what is our management? So really our first drug class that we can really go into are antipyretics. So acetaminophen, Tylenol, and ibuprofen, so your Advils and your Motrin. And like I said, that's really just to assist with the discomfort of the fever. They're relatively safe and they're effective in children, but there are some side effects that can come with these medications. So with acetaminophen is hepatotoxicity. And then with things like ibuprofen, it could be metabolic acidosis and possible renal failure. But in general, there haven't been any effects on recurrent rates of febrile seizures when using these types of medications. So you would, like any person would think, okay, the febrile seizure is a fever that's causing the seizure, right? Maybe I need to prophylax them around the clock, 24 hours a day. If they don't get the fever, they won't get the seizure. That's not the case here. So that's another point that we have to educate parents on. Another drug class that we can use are benzodiazepines. So here, these are really reserved for prolonged seizures. So seizures lasting greater than 5 minutes, and they're in the IV formulation like Iris mentioned. So do you guys remember which 3 benzodiazepines she mentioned? Yes, good job. What about if there is no IV access? What should we use? Rectal, correct. So we can use, and we can also, as Dr. Sue mentioned, the intranasal, which hopefully will come out soon. So prophylacting. So do we prophylax these children with antiepileptic medications? So studies have shown that when the seizure is recurrent but it's brief, they really don't warrant any type of treatment. Like I said before, the number of risk factors that you have increases your chances of developing another seizure. So the more risk factors you have, the more likely you are. And actually studies have shown if the patient has 4 or more risk factors, they're actually at a 70% chance of developing a recurrent seizure, while children who have less than 4 can go anywhere from 20 or less. Also, studies have shown that these types of seizures don't really cause any type of brain injury, and there is no benefit in preventing the seizure with intermittent medications. The only time that it is acceptable to use these types of medications is more so for prolonged repetitive seizures, and that's when the benzodiazepines are not efficient, so when they're not enough and then they need something else on top of it. So there we can use additional treatments. So does anyone remember what Iris mentioned as additional treatment? I'll give you okay. Phosphonatoin. Yeah, so phosphonatoin, phenytoin, possibly levetiracetam, and even phenobarbital. So it could be used, but there's only a few cases where it should be used. So here brings up my next point. So phenobarbital. So it's effective in preventing recurrent simple febrile seizures, but there's a problem with its use. It causes severe adverse effects. So it can affect the child's mood, it can affect their behavior, their cognitive function, and even cause hypersensitivity reactions. Studies have also shown that long-term use is actually associated with the increased risk of depression, impairment, whether that's short-term memory, attention, or even concentration. So really we have to weigh out the risk versus the benefit. Does our child really need to be put on phenobarbital? Is it really going to benefit him in the long run? And now I have our patient case. So let's say his name is Mickey Mouse. He's this cute little kid here. He's a 12-month-old male who presents to the ED with convulsions that last less than 5 minutes. He weighs about 9 kilograms, and he also has a rectal temperature of 102.3 degrees Fahrenheit. The patient's now alert, but he appears fussy, he's uncomfortable, he is crying. Which is the most appropriate treatment option for MM? So, who thinks A, diazepam? Mind you, pretend like these doses here are correct. I don't want you to have to calculate anything. Just assume that they're all correct. What do you think our first line treatment is here? Does anyone think diazepam, A? Okay. Does anyone think B, midazolam? What about C, phenytoin? And D, acetaminophen? Perfect. So the reason why acetaminophen is the answer is because this is actually a classic simple febrile seizure. So although he did have the seizure and it lasted 5 minutes, he's now alert, he's awake, he's orientated, but he's fussy, he's uncomfortable. So really our only treatment here is to treat his symptoms, which is his fever. So that's the answer. And now I'll pass it on to Dr. Sue.
And one thing to also note, thank you, is that we found out the hard way with phenobarbital when we were using it in the past all the time for febrile seizures. We found out when these kids were followed up, when they turned, let's say, school-age kids, their IQ were actually lower than the ones who've never been treated with any type of phenobarbital. So that's why it's not, so there are risks with using these anti-epileptic drugs. They're not always considered safe. And that's why we have to take a look at to see is it more beneficial to put them on medication versus just not putting them on any medication. So now this turns back to the rest of the other disease states that we're going to talk about, specifically with seizures. And probably the two that really overlaps the most between pediatrics and adults are your focal seizures, also known as the past as partial seizures, and your generalized seizures, which we'll talk about next. So I'm just really going to go over these very briefly, talk about like the differences between the clinical signs and symptoms among adults versus kids, and what drug we use as our drug of choice. So the first one we're going to talk about is the focal seizures. Focal seizures is more common so that we see in kids versus generalized seizures. It used to be called partial seizures itself. So take a look at the difference between infants versus children and their signs and symptoms. So infants usually may have like some lip smacking, chewing, repetitive swallowing, and it's not easy to see. So when you have an infant who's having a focal seizure, let's say they normally take in a pacifier or suck on their thumb or something, it's hard to kind of see if they're having a focal seizures because you're seeing these mouth movements, but what if their mouth movements are like you take away their pacifier and they're still having those mouth movements. So it's a little difficult for family members sometimes to observe because they're not having like tonic-clonic seizures, for example. And then for a child, this is very interesting with the focal seizures. For a child, it's very subtle. It's I had a kid that with focal seizures that he would just all of a sudden run out of the room, run from down the hallway and then run back and then go back to his room. Or you may be talking to him and then he's picking at his clothes constantly, but he's actually having a seizure activity during that time. So it's not something that family members can observe all the time right away. So hence why when they come into the hospital, if we want to look at their EEG, it may be normal. When we put leads on their head to check their EEG recording, it may be normal. Therefore, sometimes we do a video EEG where we record them while they're for 24 hours while they're in the hospital. And if if we see anything on the monitor that their EEG is abnormal, we play back to the video during that time of what that child is doing. And that's how we can tell family members what to look out for. So are they eating and then all of a sudden they stop eating and they're doing something unusual and then they go back to eat? It could even take less than a minute for them or a few seconds for them to have that seizure activity. So if we inform family as we're recording their video in the hospital, seeing what they're doing, when they're in the hospital, we can actually kind of tell parents like this is the normal thing that your child does, and that may tell you they're actually having a seizure activity. Because we're not going to send these kids home on an EEG monitor. You're not going to know when they're going to have a seizure unless you look for all these other signs. So what do we use to treat for focal seizures? The drug of choice is oxcarbazepine. So your oxcarbazepine, also known as your trilactone, is your drug of choice. And with this agent, there's other alternative agents that can be used, but any initial drug therapy that's used for focal seizures is always going to be your oxcarbazepine. And then we're going to talk about, with this, oxcarbazepine versus alternative agents. Now, there are a lot of alternative agents, and they're all equally efficacious. The only difference that really makes them more different is really the side effect profile, which is why we use oxcarbazepine as one of our first-line agents for initial therapy. For refractory seizure, partial seizures or focal seizures, in very, very severe cases, you may be able to use felbamate. The only problem with felbamate, which makes us like the last line agent for severe focal seizures, is because felbamate has two major adverse effects. Does anybody know what those adverse effects are? Okay, they have hepatotoxicity, and which can lead to significant liver failure that actually may require liver transplant. So that's always like no-no. The second thing is aplastic anemia. So felbamate is not a medication that you can easily, readily prescribe for them. This is used for our very severe refractory focal seizures that we see. And with this, and it's mainly because of those major FDA warnings and adverse effects. So it's really only used as adjunctive therapy, as last line, when all those other alternative therapies does not work. Then you have your generalized seizures. Now, generalized seizures, and we're going to focus mainly on tonic-clonic, because in most of the cases, if our kids come in not only with tonic, they usually come in with a combination of tonic and clonic generalized seizures. There are many first-line options. So you really could choose any of those, but you want to take a look at the risk versus benefits of each one of those. So you know phenytoin, fosphenytoin, those have significant adverse effects. So does phenobarbital. You have to check levels. Valproic acid, if your kid is 1 year old, you probably don't want to use it because you don't want to use it because they have hepatotoxicity risk in less than 2 years of age. So your best option out of the agents for generalized seizures is really what? Probably like topiramate or even carbamazepine. So with generalized seizures, we take a look at the risk versus benefits. Take a look at, even though those are all acceptable first-line agents, there is a best first-line agent. And in this particular case, most of the time, we would actually start with the topiramate instead. So this is just a picture to show you about the tonic phase and the clonic phase. So you can see the severity, and keep in mind when they are in a tonic-clonic generalized seizure, they do this continuously, nonstop, until they're well-controlled and seizure-free. So, so just think about this movement as continuous movements. Now, another unique seizure that we see in pediatrics is something called JME, juvenile myoclonic epilepsy. This is a unique seizure. Based on its name, it basically is what it says. It's a juvenile epilepsy. So it usually occurs during adolescent time, usually around 12 to 18 years of age. And it's considered a triad, meaning that there's 3 different types of seizure in one. So JME has 3 seizure types. One of them being generalized seizures. Doesn't have to be a combination of tonic-clonic. It could just be generalized tonic or generalized clonic. There's also epsilon seizure with it, and there's also myoclonic jerks with it as well. So there are 3 types of seizures in this, and that's why it's called a triad with JME. The other thing that's unique with JME, and usually we see it as peak during adolescent time, is because usually this is due to sleep deprivation. So as kids get older, they tend to sleep less, especially when they get to high school. And for some reason, we see during that time, maybe from the sleep deprivation that they've had, it actually showed and forecasted their type of seizure. The other thing that's unique about it is that it's usually genetically related. So it does have genetically inherited as an autosomal dominant trait. So that's another thing. If we have a significant family history of some type of seizures, maybe what they had was actually a JME type of seizure. So it's unique to pediatrics, and especially during the adolescent age. So how do we treat it? Well, there's one main medication that actually treats the triads: topiramate and valproic acid. So these 2 are considered first-line agents that you can use to treat JME. So what's the difference among the both of them? The main difference among them is that valproic acid is not a bad drug other than it causes hepatotoxicity, but it is effective in reducing all the 3 seizure types. Now that we have topiramate on top that's available, you can also use topiramate as one of your first-line agents as well too. There's also other agents, adjunctive agents. If they're on valproic acid and they're on topiramate, and let's say it's not enough, you can also add on top of that levetiracetam, so also known as Keppra. Now, the drugs that can worsen JME, and it's either because there's 3 types of seizures with it, is any of these. So you never want to use any of the carbamazepines or oxcarbazepine, phenytoin, tiagabtin, vigabatrin, or gabapentin. If any of these are misdiagnosed with JME and you start any of those agents, they're going to make the myoclonic jerks and seizures even worse. So those are the absolute no-nos that you want to use, that you do not want to use for JME. So those are the seizures worsening those agents. The other one that usually, the type of seizure or syndrome that usually occurred during childhood is something called LG syndrome, which is also known as Lennox-Gastaut. This is probably one of the saddest group of seizures to see. So we just talked about JME, which had 3 different types of seizures that makes up the triad. This one has 5. That's why it's called a syndrome. So we're talking about 5 different types of seizures: the myoclonic, generalized tonic-clonic, the partial or focal seizures, absence, and atonic, all in one syndrome. Okay, so you can see there's many different types of seizures. This usually peaks around preschool childhood, between 3 to 5 years of age. Now, they do live till adulthood. They do live till adulthood and they get treated, but they may develop additional other seizures on top of the 5 they already have for their syndrome. So, and the reason why I say it's very sad is because most of the time, most of the kids that have Lennox-Gastaut syndrome are cognitively and not neurologically normal. So they usually have some type of cerebral palsy, and either they had a history of a very severe seizure attack that led to a diagnosis of this, or they've been refractory to multiple different types of medications, which is usually what we see. So they're more, status epilepticus is very frequent. It's normal for a family who has a child with LG to say that, oh, you know, their baseline seizure is about 20 a day. 20 a day meaning that they have seizure activity that can be convulsive 20 times a day. And that may be their normal baseline. So of course, if that's their normal baseline and they come into the hospital with, like, say 30 of them, we want to get them back to baseline as soon as possible. Even though that sounds like it's not good enough, but we got to get them to 0. 0 is very hard for LG to get to, you know, what their normal is. If we can get them back to normal amount of seizures per day, that's good. And then when we get back to normal, okay, maybe then now we'll try from their baseline seizures of 20 a day to maybe get them down to like 18 or 17. So it's not unusual for them to normally have seizures every single day. The prognosis is very bad. Most of the time they do have retardation. And we're going to talk about infantile spasms in a little bit, but most of them are initially, as an infant, diagnosed with infantile spasms first before they develop LG. So LG is very similar to JME that we just talked about. Valproic acid really does help for all 5 types of seizures. So it's really indicated for all 5 types of seizures. Hence why valproic acid is listed here as a choice. And then you have alternative therapy. So as a drug of choice, valproic acid is preferred. Majority of the time, they're probably not going to be controlled with just valproic acid. These are the kids that are usually on 3, 4, or 5 anti-epileptic drugs to help with their seizure activity. So all the alternatives that you saw earlier are mostly what they're on. But we will start with valproic acid first because we know it helps for all 5 of those seizures in that syndrome. Alternatively, we may give them also something called a ketogenic diet on top of their drug regimen. And I do have a slide later on to talk about what a ketogenic diet is, but it's basically a diet that's very high in fat, that is an adjunct on top of drug therapy to help them. So it's more of a dietary and nutritional management. We get our nutritionists on board to give them a very, very high fat diet, almost like an Atkins diet, on top of their other drug agents as well. So it's really more as a nutritional adjunctive therapy. Now, drop attacks. Drop attacks are your atonic seizures. So what does that mean? So with LG, when they have a atonic seizure, they lose all muscle tone and they fall flat down. But what do they hit first when they hit flat down? What body part do they hit first? Anybody know? Drop attacks. Their head. Okay? So when they become myoclonic, meaning lose all their muscle tone, they basically, atonic, meaning they lose all their muscle tone, they drop down to the ground and hit really hard, but they hit their head first. So most of the time with these kids, you'll see them with a medical helmet on. So a helmet that's usually cushioned up so that they have that on in case they have any drop attacks, that they won't have a head trauma when they fall to the ground with their seizure. So with those, if we have a high occurrence with LG with those type of seizures, we'll generally add on some agents such as topiramate, lamotrigine, or clobazam to the valproic acid if they have a large number of drop attacks. And those do help with the atonic part of the seizure activity. Now, LG just a few years ago had a drug that was really, we were very impressed because it came out and it was called refinamide. Refinamide, also known by the brand name of Banzel, was the first real drug that was approved for LG. Valproic acid wasn't officially approved for Lennox-Gastaut, but it was basically had these other indications for seizure activity. So refinamide was one of the first ones. And with this agent, it is indicated for greater than equal to 4 years of age, and it does reduce the number of seizure activity that you can use as adjunctive therapy on top of the other agents that the kid may have been started already. The main thing with this is I do want to talk about the adverse effects. So they have very specific drug-drug interactions. And these drug-drug interactions you'll notice are specific with other anti-epileptic drugs. So the nice thing about it is that when you use it with refinamide plus valproic acid, which has been the landmark for LG, you'll notice that nothing happens with the valproic acid levels. So how do you read this? If I use refinamide and valproic acid together, refinamide does not affect valproic acid concentrations, but instead, your refinamide concentrations may go up higher. And that's how you read these drug-drug interactions. On the other hand, if I use the other three combinations, you'll notice that they interact each other and refinamide concentrations may be lower, which you do not want. Now you do have to worry about when your refinamide concentrations are high also because of its unique cardiac adverse effect. So when you think about cardiac effects, drugs that usually affect the heart, do they usually shorten the QT interval? No, they usually do what? They usually prolong. So don't get that incorrect on the exam. Most drugs will prolong the QT. Refinamide, for some reason, shortens the QT interval, which is unique. So anybody who started on refinamide, absolutely, we will give a baseline EKG on them to make sure that they have no underlying congenital or heart defect. And it also causes multi-organ hypersensitivity reaction, which may potentially lead to lymphedema, so lymph nodes may be increased, and they may potentially have liver toxicity, other organs may be damaged. A lot of anti-epileptics can cause this too. And then other ones are listed there, but the main thing that makes this drug different is the shortened QT interval. Another one that was available just a few years ago was clobazam, also known as Amphi. Now, clobazam sounds like what class of medication? It's a benzodiazepine, okay? So it's a benzodiazepine, but it's a longer acting benzodiazepine. It's available orally, so you can give it chronically. Okay, so this one particularly is not used in emergency situations. So with clobazam, we can use it for, it does reduce the drop attack activity, but it also is mainly used as adjunctive therapy. So you still need your valproic acid for LG, but you can add this on top of it if they have also drop attacks. And that's another agent to keep in mind. Now, being a benzodiazepine, you do have to worry about the adverse effect with benzodiazepine. You do have to worry about sedation, They may be a little more sleepy. So, and you can't just abruptly stop it, because if they've been on it for a long period of time, and you can consider to wean them off, but you have to wean them off. You cannot abruptly stop it. They're gonna have withdrawal due to that. All right, and then now we're gonna talk about one of my favorite seizures, which is epileptic spasms, also known as infantile spasms. Epileptic spasms is the new name for it. It used to be called infantile spasms, and the reason why they changed it was because we found that it's not a seizure that only happens in infancy. It can progress beyond infancy, so it can progress past 12 months of age. And hence why they changed the name, because it really shouldn't be known as infantile spasms. So it's now known as epileptic spasms. And with it's a triad of West syndrome, which includes infantile spasm, hypsarrhythmia, and psychomotor arrest. So what does that mean? Hypsarrhythmia means if you look at an EKG, and when the patient is in arrhythmia, the EKG looks like it's crazy lines going up and down, right? Same thing for EEGs. Hypsarrhythmia and EEG monitoring for infantile spasms is just the readings of the EEG are peaked every time and they go crazy. And that's how a neurologist generally can diagnose it. The psychomotor arrest is that after they have it, the babies are exhausted and they just sleep most of the time. So that's what the psychomotor arrest means. And the peak onset is usually 4 to 8 months of age, is usually when they diagnose it. And the pathophysiology, it may be due to an increase in something called CRH, which is corticotropin releasing hormone. And that's why when we talk about the treatment, it's going to be very unique. So clinical manifestations, I have it listed here, but I'm going to also show you a video of a baby who has infantile spasms. And if you think about it, if we usually diagnose between 4 to 8 months of age, a lot of times these infants are healthy infants, nothing would have known. Most of the infants I've always had that diagnosed with infantile spasm, nobody had any risk factors, nobody had any, none of those babies were premature babies or had a significant family history of seizures. So let me show you a video first. Let's see. But you'll see that once I show the video, you'll see that this baby is going to be very subtle. Just log in. Okay, let's do this again. Let me see if I can get back to it. All right, watch this little baby. See that flexion? Okay, the arms are gonna flex. And the baby can have 40 of those in 1 minute, continuously. Now, if a parent doesn't know any better, when they first see these flexions, they may think that they're startled, like maybe they were just scared something happened. But the more repetitive it becomes, because each time it'll look like that, they'll notice that something is wrong. Okay? And that's the flexion of the arms and also the legs that you'll see, usually with infantile spasms. So it's very unique. And we haven't even watched the video for a minute, and this baby has had multiple versions of it. Okay. So I mentioned earlier that these babies are, may prolong to have LG in the future. And epileptic spasms is one of those seizures that can lead to LG. So sometimes they may have subsequent. Babies who are diagnosed with epileptic spasms, up to 90% of patients will develop psychomotor retardation. So that means only 10% of these babies who have this diagnosis will actually be cognitively normal, go to regular school, graduate, etc. 90% of them will have cognitive developmental problems. I've only had one baby, a success story, that's now meeting their milestone, and the mom will like send me videos, and she's on Facebook and everything, and now the baby is 12 months of age and she's walking. You know, I've only had one case out of all the cases I've had to do with epileptic spasms. So it's not something that we like to, diagnose, but when we diagnose, we know exactly what to start them right away. And these are the emergency medications you need to have. So for infantile spasms, something called ACTH, so very unique to be used, and it's also known as Acthar gel. But there's also alternative therapy as well, which we'll mainly talk about is vigabatrin. Now, corticotropin, also known as ACTH and also known as Acthar gel. We just went over what was the pathophysiology of epileptic spasms. They have some type of hormone malfunction, okay? So what do? We give them those hormones. Okay, we give them that steroid that will produce the corticotropin releasing hormone, and that's exactly how this drug works. The mechanism of action is to suppress the corticotropin releasing hormone, and its efficacy is much more better than oral corticosteroids. So what corticotropin is just a very potent corticosteroid, but it's much more effective and much more potent than your regular oral corticosteroids that are available out there, such as prednisone, methylprednisolone. This one is one of the more potent ones. That's why your side effects with ACTH are going to be very similar to any type of steroid side effect. You're going to have increase in blood pressure, so potentially hypertension. You can also have increase in heart irritability. Very severe cases with this drug, it can lead to brain atrophy, and that's just due to the high dose steroids over a long period of time. And those are the side effects that when we go over with the family, that usually scares the family with them. And because it's a very potent corticosteroid, you are suppressing their immune system. Okay, so if it's during the winter months when you know viral season, may be more higher, the kid may have much of a higher risk of not being able to fight an infection because they're on this potent corticosteroid that's suppressing their immune system. So in very severe cases, they may need PCP prophylaxis with trimethoprim or sulfamethoxazole. So a lot of side effects, even though we know the drug does work, but a lot of adverse effects. Then you have another drug, and I can't say one is better than the other. They're both just as bad sometimes, but they work. They do work, and when we start them right away. So vigabatrin is also known as Sabril. Both agents have to go through something called a REMS program. Does anybody know what a REMS program is? Okay, a risk evaluation mitigation program. Things must be clear with the family members, the caregiver, before they start this medication. They have to know all the risks, the family members. So vigabatrin is one of the unique anti-epileptic drugs that has a very, very unique mechanism of action, different from all the other ones you've learned before. And it mainly works by irreversible GABA transaminase inhibitor, raising GABA concentrations in the CNS. So it prevents the breakdown of the enzyme that breaks down GABA. And if you have more GABA in your system, remember GABA is what? Is it excitatory or inhibitory? Inhibitory. So you have an increased level of GABA. Now, the other thing with this drug is that it is less effective than ACTH. That's why ACTH is considered the drug of choice for infantile spasms. But if you have an infantile spasm or epileptic spasm baby that has something called tuberous sclerosis, which are lesions inside their brain, then vigabatrin is the drug of choice. So let me repeat that. ACTH is still considered the drug of choice for infantile spasms. But if you have an infantile spasm baby with tuberous sclerosis, meaning lesions that they have in the brain when you do an MRI scan, the vigabatrin is shown to be more effective for that. And that's when that will be the drug of choice. Now, we talked about ACTH. We talked about how it has the same adverse effect of steroids. It's a little different with vigabatrin, and it gets a little upsetting when I have to go over this with the families when we fill out the REMS program, because every family member I counsel has always generally cried. And it's mainly because of the retinal toxicity. So if I discuss it with a family member, they're not going to know what does retinal toxicity mean. What does that mean? It just means that 1 in every 3 people that get treated with vigabatrin can have retinal toxicity, which means that they may have potential peripheral vision loss. And 1 out of 3 is what? 33% of the population. Okay, that's very high. So if I tell a family member that there's a 33% chance that their child can have potential vision loss, that means to the family what? Child will never drive for the rest of their life, and they probably will never, they basically will have tunnel vision for the rest of their life. And this is permanent, this is not reversible. Hence why it goes to the REMS program. So they're gonna have tunnel vision. So if you imagine, if you don't have your peripheral vision and you just see tunnel vision like, and it's permanent, that's how the family minds is like, their child is never gonna be normal. Because we have to tell them, and it's part of the REMS too when they sign for it, that they know it's permanent and it's not reversible even after you start the drug. The good thing is that we don't know most of our kids have been fine with their vision, because as soon as we start them on this medication, we stop the medication as soon as we get them controlled with their infantile spasms. And generally, we try not to keep them on it more than 3 months. Do we know if that really helps? We don't really know, but until we get more information to see if maybe potentially this vision loss may be due to duration or dose related, we don't know that right now. But what we do know is permanent, and even after you stop the drug, it's not reversible. So that's some of the things to keep in mind. Now there's alternative therapies also, but the key thing to remember is vigabatrin is used as drug of choice, and also only if they have tuberous sclerosis with the infantile spasms, and ACTH is the drug of choice. So this is the link to the video that you can take a look at later if you want to see the video. There's multiple videos of this as well. All right, I'm gonna end with the last seizure, which is neonatal seizures, and then we have a little case we're gonna go over also. So let's talk about neonatal seizures. And with neonatal seizures, it accounts for about 0.5% of term neonates and 20% of preterm neonates, meaning that the more premature they are, the more likely they're gonna have a seizure activity. Neonatal seizures is mainly because they're immature. They have immature neurological firing, and sometimes they may irregularly misfire. And we want to, of course, rule out any type of other problems as well. So make sure that they don't have a vitamin, deficiencies such as pyridoxine deficiency. Make sure that their seizure activity is not caused from drug withdrawal. Maybe the mom was taking heroin or methadone, and it's not because of withdrawal of drug that the baby is seizing. So if it's truly a seizure of neonates, we can easily treat them with 2 types of medications. Our first line therapy is phenobarbital. So everything that Giselle Trangoso just went over with febrile seizures is like the opposite with neonatal seizures. In neonatal seizures, the drug of choice is phenobarbital. And the second line therapy is going to be your phenytoin. Now, some things to consider about with neonatal seizures. It's very hard to diagnose. These are some of the clinical signs and symptoms. Sometimes we may have eye fluttering. A lot of times nurses do see, or parents do see, is something called pedaling of the feet. So if they're laying down, just imagine their legs trying to pedal like a bicycle while they're laying down, and that may be a seizure activity. So phenobarbital and phenytoin. Majority of the time, we need to use combination therapy. Oftentimes, when we use phenobarbital, it's only 50% effective. But if you give them phenytoin as adjunctive therapy on top of the phenobarbital and using combination, our efficacy actually increases. Of course, we always want to start off with monotherapy, so we give phenobarbital first, and then if we need to, then we add on the phenytoin on top of it. So the question comes, well, are these babies going to have cognitive or IQ problems or aggression or attention problems if we start them on phenobarbital? We don't know that answer. And why don't we know that answer? The reason why we don't know that answer is that we don't know if these neonates were neurologically normal before we started them on the medication. Did the seizure activity cause them to have neurological problems, Or is there something underlying that they had the seizures that's causing it? We can't rule that it was phenobarbital that caused this cognitive or IQ delay later on in life. As opposed to febrile seizures, those kids were generally normal milestones, no indication from pediatricians or the pharmacists that something was wrong with the child, and that's how we can follow up and see if they had a deterioration in their neurological development later on. It's hard to do it in neonates where you don't know, where there could be other problems going on, and if you don't know if that single seizure episode that they had caused any damage in their neurological function. All right. Now I know I have in your handout a lot of other special considerations in pediatrics. I won't test you that for the exam. It's just really for your own knowledge, but I want to give some time for Iris. We have about a few minutes to go over briefly a case that is going to be similar to some of the test questions that you may have on the exam. Pull the slide up. So our case is actually going to be based off of my last question. So if you want to refer back to my last question, it might be helpful. Okay, so MM, again, he's our 12-month-old male who presented to the ED with convulsions that lasted less than 5 minutes. His current weight is 9 kilograms, and he has a rectal temperature of 102.3. That began 3 hours prior, okay? He does not attend daycare, has no family history of seizures, and this is the first time he's ever experienced this type of febrile seizure. So based off MM's subjective and objective information, how many risk factors for reoccurrence does MM present with? So if you want me to, we can talk this out, because I like talking things out, especially when I take exams, I kind of talk to myself. So what's the first thing that we automatically know puts him at risk for having a seizure again? His age, yes, he's 12 months old, so anything less than 18 months of age will put them at risk. The fact that he's already had a seizure and it was related to a fever also technically puts him at risk, but that kind of goes together. What about looking at his family history? No, so he's had no family history. So that technically, based off my chart, if he did have one, that would put him at risk. What about the fact that his seizure started 3 hours after his temperature? No, right. So if it's less than 1 hour, that puts him at risk. So how many risk factors do we have then? 1, correct. So now the next question. So this one we can also talk about. So he already received the acetaminophen, that was my first question, by mouth every 4 hours as needed. He's now ready for discharge. But mom and dad are worried sick. They have no idea what to do. This is the first time that they've ever seen this. So they ask you, the pharmacist, if what to do if his seizures start again. So what major counseling points can we tell the family in regards to the seizure, not necessarily medication? Put him on his side, perfect. What else? Don't try to hold him down. What about his mouth? Make sure there's nothing in his mouth, correct. Does anyone know why we shouldn't have anything in the mouth?
Choking.
Correct. So choking, and then also he might bite his tongue, and that's something that normally happens, so we don't want to try to prevent that and have something worse come about it. So also we should have her call 911 as soon as possible, but the same things that we just talked about. So put him on his side, making sure nothing's in his mouth, and try not to stop the jerking movements. So our third question. So Emma mother's still really concerned that he's gonna have another seizure. She wants to know if we can prevent them from happening. As a pharmacist, what information that we just learned about should we tell the mother about fevers that reoccur? It kind of goes back into our risk factors. So how many risk factors did we say he had? 1. So do you remember what I mentioned earlier, more risk factors leads to more reoccurrence? So his chance right now is, what would you say? It's pretty low. Yeah, so we can kind of reiterate to the mom and say, you know, right now he's only had 1 seizure. It hasn't reoccurred in the past 24 hours. You know, this is his first time. He doesn't have family history. So his risk of this is actually low. And also,
with these short febrile seizures, there is no real risk to brain injury as of right now. So she can, hopefully it'll make her feel better. Another thing that we can tell her about is that there are no benefits to preventing these types of febrile seizures. And as we hopefully remember, the reason why is that intermittent medications really don't prevent it. Also, unnecessary medication, what is it going to do? It's going to cause more side effects and ultimately harm the child more in the future. So if we were to talk about phenobarbital, what were some of the long-term side effects that we mentioned? Shout it out. Memory impairment, perfect. What about something else? Depression could also affect their cognitive function. It can cause a lot of issues that can affect them into their adulthood. So we really have to weigh the risk over the benefits. And this is something that us as pharmacists can really do, especially with parents who are concerned. Because you also have to remember, this is scary. This is not something that someone would like to see their child experience. So providing them this education can really, kind of put them a little bit at ease, but also explain to them what are the warning signs, what to do in the event that it is to happen. And now I'll pass this on to Iris.
Okay, so unfortunately 3 days later, MM's mother notices him seizing again and calls 911. She does everything that you guys just talked about counseling point-wise. And emergency medical services arrive on the scene. After stabilizing him, proceed with initial therapy. So of note, they were unable to establish IV access, so which agents can still be administered here? So we've got 2 major drugs in initial therapy that we can still give, right? That don't need IV access. Do you guys remember what they are? Okay, midazolam I heard. So which routes of midazolam can we give? Yep, IM. There's 2 others. Intranasal and buccal, yep. And then what's the other drug that we can give? Diazepam, yep, and that's rectally. So again, still a lot of options, even if you IV access. So at this point, it's been 20 minutes since the onset of the event, and chosen initial therapy doesn't stop MM's seizure. So they're still en route to the hospital, but the team was finally able to gain IV access, and they move on to second therapy. So which of the following is most appropriate? So I'll give you a sec to look over these, but we'll go over them one by one. So does anyone think it's A, 2 doses of IV levetiracetam 5 minutes apart? No? Okay, B, a single dose of IV valproic acid. C, a single dose of IV phosphonitone. Okay, I see a lot of hands raising for that. And then D, 2 doses of IV phosphonitone 10 minutes apart. Okay, so you guys are correct. It's a single dose of IV phosphonitone. Remember, for second therapy for these options, you just give it as a single dose, so that's why options A and D are not correct. And then for B, a single dose of IV valproic acid, remember this child is less than 2 years old, so we worry about the hepatotoxicity. So at 50 minutes since the onset of the event, MM arrives to the hospital, though they're still seizing. What options are still available to the medical team at this point? So this is third therapy now, where there's not as much evidence-based therapy, but what are the options that we could still use here? So there's 2 major choices you can make. You could do, you could repeat second-line therapy, and then what other option do you have? IV phenobarb is a potential option. That's one of the potential second-line therapies, and I heard anesthetics over here. So that's correct. So the anesthetic doses of midazolam, pentobarbital, or propofol, and then again, what do you have to make sure you do if you do decide to use the anesthetic doses of these agents? Intubate. Right. So you have to make sure they're intubated. So that concludes our case for this lecture. Thank you.